We reported the results of a prospective trial evaluating the role of circulating tumor cells as a prognostic biomarker for late recurrence in women with breast cancer, early stage breast cancer. We took patients who had previously been enrolled in a previous ECOG trial, the E5103 trial, which was a high-risk population that included patients with node-positive disease or high-risk node-negative disease. They all received standard chemotherapy, including dose-dense or every 3-week doxorubicin and cyclophosphamide, followed by weekly paclitaxel, plus or minus bevacizumab, followed by endocrine therapy if the tumor was ER positive, and they all received at least a 5-year course of endocrine therapy as per the physician's choice. And it turned out that the addition of bevacizumab didn't impact on the overall outcomes of the trial. It was a negative trial. What we did was we focused on a subset of the patients who enrolled in the trial who were alive without evidence of recurrence, clinical evidence of recurrence, between 4.5 to 7.5 years after diagnosis. And we asked a simple question. We asked them to enroll in another trial, a prospective trial, where the patient then donated a blood sample at baseline and then annually for 5 years. And the initial blood sample was an analysis for circulating tumor cells using the cell search platform, a platform that identifies EpCAM positive, epithelial marker positive circulating tumor cells. We did not report those results back to the patient or clinician because we weren't really sure what the value of that information was. We enrolled 547 patients over a period of about 3 years, at which time we closed accrual, and then we evaluated the outcomes about a year later. We had two primary objectives. The first objective was just to determine what the prevalence of CTC positivity was in this population. And these patients were followed for a median of 5 years after diagnosis. And the second was the presence of CTCs in the blood associated with an increased risk of recurrence? And we found the following. First of all, about 5% of patients were CTC positive 5 years after diagnosis. So these are patients who were clinically without evidence of cancer, but yet had circulating tumor cells in their bloodstream. These patients did not have imaging done at the time of the CTC because the trial was not designed in that way. We simply followed these patients. And what we found was that for the patients who had estrogen receptor positive breast cancer, that the presence of a positive CTC test was associated with about a 20-fold higher risk of recurrence compared with those who were CTC negative. And that included models, multivariate models, where there was an adjustment for clinical covariates. We also found that the presence of CTCs did not correlate with any baseline clinical covariates like age, tumor size, lymph node status. The second thing that we found, is that the CTC positivity was associated with this markedly higher risk of recurrence. So the main conclusions from our trial, at least for patients with estrogen receptor positive disease, where all of the recurrences, the distant recurrences occurred, was that this could be a biomarker that's prognostic for late relapse. It demonstrates, we know that it's an analytically validated test, so it has analytic validity, and our trial provides for the first time evidence of clinical validity. That is, that the presence of a positive test is associated with a specific clinical outcome, that is, recurrence of disease. What the trial didn't show, what the report didn't show or demonstrate, was clinical utility. That is, can this result in a treatment change, and do patients benefit from that change? And we're currently in the process of designing additional prospective trials to help identify what is the clinical utility of this information and of this assay in this particular setting.